So we have our own Lily Jeong talking to us about hyponatremia for our last talk of the morning. Um,
Sorry, I for some reason can't figure out how to turn back on my camera. 1 second.
Usually if you're sharing your screen, there's sometimes like a thing on the top where it goes to.
Sorry, 1 sec.
You're fine.
I will do this.
Now I can see you. So I think now if you share your screen, you will
now
still
I'm gonna do this.
Yep.
Do you only see my presentation?
Yes, I see what the slides only. I don't see like presenter mode. So I think we're
excellent. Good. For those of you who don't know me, my name is Lily. I'm a third year, and for those of you who do know me, know that I am obsessed with hyponatremia. A lot of residents are brave and like do academic half day talk on issues that they don't know very well about. So they like take it as a learning opportunity to like teach themselves and then like disseminate information. I kind of wanted to do that this year, and then like I kind of felt like I was doing myself disservice by not talking about hyponatremia for like potentially last academic half day talk. So I just decided to indulge myself and do this. So thank you for humoring me this morning. Hopefully this is an informative talk. Okay. Why isn't my slide moving? Oh, there we go. I have no disclosures. So hyponatremia is a notoriously hated and confused, like disliked topic. You can just the amount of memes that are out there. Like I think there's like a hyponatremia meme like every week at least on some medical subreddit. This is honestly initially why I got interested at first. I was like, why can't I learn this? Why is it so confusing every time? And like, why doesn't it stick? So I was just curious, I would love to hear from you so that I can like maybe gear my talk a little bit throughout the morning. Like, what do you dislike about hyponatremia if you just want to share in the chat? Okay, so Gina's like, I can never remember the algorithm. That's a hard one. A lot of numbers. Oh, wow. Many opinions. I love it. Million different ways to categorize. Yes, there are a lot of categorization. And hopefully I can convince you today that there is one right way to categorize things. Okay, so a lot of people are saying flow charts, they're algorithms. It's hard to remember. You get the serum osmosis. Okay, great. Austin, I'll touch on that today. The pawns will die. Yeah, that we always freak out about, like, oh my God, are we overcorrecting, right? Yeah, it's a pain in the butt to follow up on the Q4 checks. Oh, Magna hates the EDH pathway. Cover your ears for the next 30 minutes. Yes, always. Yeah, Adrienne says they always give fluids before urine studies. I don't know if I can help in that department, but I can tell you that during my ED rotation, I ordered urine studies like a crazy person. It's very disappointing me. You will never disappoint me. Because I swear, like, this is one of my favorite topics because like every time I think about it, I think I get it. And then the next time I think about it, I'm like, I don't get it. And I guarantee you that like you're gonna ask questions today to me where I'm like, you know what? Yeah, that doesn't make sense. Why is it like that? Salt tabs are gross. These are all okay. So the general theme that I'm hearing is the algorithm's confusing. I can never remember the algorithm. Labs aren't sometimes what you expect it to be. And like the overcorrection, that's scary. Great. So who's seen this algorithm? this is from Up to Date. I remember one time when I was a first year med student, a resident showed this to me and I was like, oh, I look at this every time I think about hyponatremia. It's so helpful. And how, like, this is never helpful, but like, how many times have you personally pulled this up and have seen somebody else pull this up when you're like, oh my God, like, what about this hyponatremia, right? So hopefully I can convince you that hopefully after this talk, you'll never look this up again. And I can convince you a different way to go about this. So what the like main things that are really confusing about hyponatremia is like, first of all, volume status. Like why, like, are they hypervolemic? Are they hypovolemic? Are they euvolemic? Like, why is my volume exam different from the nephrologist or the cardiologist? Like, what is actually going on? And why do we even have to think about volume? And then to Adrian's point, like they already got flu as in the ED, so I was like, okay, like I can get labs. So what does that really mean? Or they're on diuretic. And I was like, okay, like then the studies I'm going to get might be useless. Like, what do I do with this information? Do I give IV fluids? Do I not give IV fluids? Am I going to overcorrect? What the F is awesome? Like, I don't even know what that means. And am I going to like kill the ponds with overcorrection? And lastly, to all like encompass this is like, why does this matter? Which one of my like dear mentors have asked me once, like, why does this matter? And I was like, oh my God, like this matters. And let me show you why. So this leads to the objective for the session. We're gonna briefly talk about the importance of diagnosing the reason of hyponatremia, why it's important to think about why it's happening. We're gonna implement an ADH-based framework for hyponatremia. Sorry, Magna. And we're going to look deeper into the causes and the pathophysiology of the different causes of hyponatremia. And then we're going to briefly at the end talk about risk factors of osmotic demyelination syndrome, which is like the most feared complication of overcorrection. Okay. So here's another algorithm that I think most of you have seen before. This is the ADH-based algorithm that looks a little better than the up-to-date one. But I think another reason why like we never remember it is like this gets drawn up on the board and somebody goes over it in like 10 minutes. And then like when they're like drawing on the board and you're like, okay, I guess that makes sense. But like we never get to like have time to like dive into actual each category to like make sense of it. So I don't know about you, I can't remember anything unless I actually think it makes sense. So today I'm gonna just like dive into each element of this algorithm and hopefully make it actually make sense, so that you don't actually have to remember the entire algorithm to like figure out what's going on. Okay, before we dive in, take a deep breath. This is a very confusing, hated subject. I guarantee you'll already know the building blocks of be able to understand hyponatremia. You just have to like put it together in your own manner, and then you'll be able to remember it and understand it. I can't help you with labs not making sense, but at least working it up, we're gonna get there. And I guarantee you that that you already know everything that you need to know. So let's talk about why this matters, because I think some of the times like we can talk about a subject forever and you're like, this doesn't really matter to me clinically. So acute symptomatic hyponatremia can lead to cerebral edema and cause seizure. So it can cause brain damage and even cause death. If you mismanage hyponatremia, which Josh alluded to a while ago, either it can get worse, like the sodium drops, and then that leads to cerebral edema and then cause a seizure or death. Or the overcorrection, we're classically taught that it can cause to osmotic demyelination syndrome and cause irreversible brain damage. And if you have chronic hyponatremia, and if you mismanage that, then it can also cause cerebral edema seizure or overcorrection that can cause complications. So really, we care about hyponatremia because undertreated, mismanaged hyponatremia can cause irreversible brain damage. That's like the most like worrisome complication. So this is why we care. Bear with me for a second. I'm going to take us back to Gen Chem. Whoever said that you'll never use this in medical school is wrong. We're going to briefly just talk about osmolality and tonicity, and I promise this is relevant. So let's say we have a body of solute, let's say water. And then you have these things dissolved in it, which we call solute. And then, sorry, the medium that the solute is dissolved in is solvent. So osmolality is just like, in simple terms, ratio of like how much solute is in solvent, right? Let's say you put another kind of cell next to it, and it obviously has more solute in this cell. And then you make the barrier in between a semi-permeable membrane. It's a fancy term for it. Let's make this just for the sake of argument. It's only permeable to solvent. So only, in this case, water can permeate through the membrane. Then this case, because of osmotic pressure, if solute can't move, right? So the solvent's going to move. So it's going to eventually look like this to equal out the osmolality. So tonicity is, again, in more simple terms, it's the oh, sorry, this is a typo. It's not solvent's ability. It's solute's ability to move solvent across the semi-permeable membrane. So like how strong, like how much, like potentially like water movement or like solvent movement can this solute cause. And this matters because we take serum sodium as a surrogate of serum tonicity. So we can measure serum osm, but we can't measure serum tonicity, like how much can serum like remove or like push water from the vasculature, right? So we use serum sodium to kind of gauge the serum tonicity. It's not perfect, but this is why serum sodium matters, because it will kind of tell you, will the serum move water in and out of the cells? Yes, I haven't lost anyone, hopefully. Okay, so the dreaded central nervous system complications that we talked about before with the cerebral edema and seizure and potentially death, that won't happen unless the serum is hypotonic, meaning that the serum is actually moving water. So if we go back to this diagram, and let's just say the left side is blood and the right side is brain cell, and then we can kind of think of the middle as blood-brain barrier, then same scenario, like water is going to move to the higher concentration side, right? So then the brain cell volume goes up, as you can see, and the brain cell will swell, and that's what causes cerebral edema. So that's what's going to cause problems, right? So to put it all together, just this like first portion, the complications of hyponatremia that we worry about, the reason why we care, doesn't happen unless the serum is hypotonic. Serum sodium is a surrogate of serum tonicity, which is why we care about the sodium. If serum sodium is for some reason low without the tone being low, the tonicity being low, so if the water is actually not moving in and out of cells, then we don't really care, even if sodium is low. So the first question that you should ask yourself when you see serum sodium low is the serum actually hypotonic? Meaning like, is the serum actually moving water in and out of the cells? So the ultimate first question is, do we care? Like, do we care about this hyponatremia? Okay, I'll stop here and take questions. Vicky, does this mean that hyponatremia will happen? Great question. It doesn't really matter, and we'll dive into that. Have I sufficiently convinced everyone that we should care about hyponatremia? And the first question that we should ask is it hypotonic and do we care? Okay. We're going to move along. So, excuse me. We're going to focus on the top part of the algorithm. The first question we ask is, do we care? Do we care about this hyponatremia? And the test we tend to get is serum osm, and I'll talk about this a little more later, because you can say, Lily, you just told me that osmolality is different from tonicity. And I can tell you when the serum osm is not the most valid thing. But the test that we first get is serum osm. And the serum osm is low, meaning there's more water, then the answer is yes, we do care. Like, we should think about this more because it means that it's hypotonic. And we're going to talk about that more because that's more interesting. If the serum osm is not low, if it's the same, or if it's like normal or higher than normal, then the answer is no, we don't really care because it's not going to move water in and out of brain cells and cause brain damage, right? To Vicky's point. So this is where isotonic hyponatremia or pseudo hyponatremia or hypertonic hyponatremia comes in. And while we don't have to fix these, I think it's important to briefly talk about it because it can mean there's different pathology going on. So we're going to focus on this for now. So isotonic hyponatremia, commonly known as pseudo hyponatremia, is, if you look at this scale as a balance of between sodium and water, you have this balance, and then there's extra volume on top of it. And what do I mean by extra volume? I don't mean intravascular volume necessarily. So if you look at this, so sorry. The left side is you drew the blood and you centrifuge it, right? And then there's usually like some amount of, like, the cells kind of go down, and then there's some amount of proteins and lipids that are in the serum. In some cases where somebody has high lipids or high protein content, that takes up more of the plasma volume, but the machine that you're testing sodium level with can't tell the difference. So the machine thinks there's more volume than the sodium there actually. So if you like compare the normal side to the hyperlipidemia hyperprotein side, like sodium concentration is the same, but the machine thinks that there's more volume. So it's lab error. It's essentially lab error. So in this case, your mechanism will be normal. And then the situations where this might happen is you have high lipids and high chylomicron, or if you have like hyperproteinemia. This can happen with like monoclonal antibodies. So like people with multiple myeloma, you might see this on hemonc actually, where like somebody comes in with like protein level of like 10 plus, then their serum sodium might be like 120 something. But that does not mean that there's water moving in and out. Like actually their sodium concentration is probably normal and it's just lab error. So now this is different from hypertonic hyponatremia, meaning on the scale, on the sodium, there's actually extra osm. So some like serum was hypertonic at some point, and then the water like already moved into the serum space to dilute it. But the osmolality, or like, but like there's no water, or what am I trying to say? So this shift already happened. So it's not gonna, it's already equilibrated, and water is no longer like gonna move into the brain space. The movement of water from the cell to the serum is already complete. So this water from serum is not gonna move into the cells. So this is kind of the classic diagram that you've probably seen since high school. If there's high level of sugar, for example, and this can happen in hyperglycemia, right? Water will just like move through the membrane. This is essentially a diagram that I showed you a few slides ago. So this can happen with glucose. So people with like HHS or DKA, this is why we correct sodium to glucose to see like what's their like actual expected sodium level if they weren't hyperglycemic. This can happen with mannitol. This is more relevant to surgical service. Like if you had pumped in like mannitol for like pelvic surgery or something like that, then that can draw water into the serum. And oh, sorry. The other thing that I was going to mention is people who have gotten immunoglobulin therapy. Immunoglobulin is more kind of closer to the hyperproteinemia that I was talking about, right? But like it'll never get that high. But they can also get hypertonic hyponatremia because immunoglobulin is usually prepared in mannitol. So just remember, because I think that's more relevant to us because we do that more than surgery. Okay. So here's a caveat. Adrian had mentioned like sometimes you get serum osm and it's like not as low as you expected it to be. What if, so going back to this diagram, you have other solutes that are actually permeable to the membrane or like just moves really, really fast. So if the red particles here can move through the barrier, then instead of water moving, the particles will just move. And then this will happen, right? So no water movement, just solute movement. And our bodies have solutes like this that can do this, like the UN. So if somebody's azotemic, this can happen. Alcohols, this includes methanol, ethanol. So somebody with like really high blood alcohol level could have this, and glycol, so like ethylene glycol, like antifreeze toxicity. So we call these ineffective osmoles, meaning, yeah, they're awesome. It can potentially move fluids, but it moves too fast to create like tonicity difference to move water. So like instead of moving water, they'll just move themselves, right? So I think this is when serum osm doesn't make sense. And like how many times do we have like azotemic patients, right? So nephrologists actually, like a lot of nephrologists don't get serum osm because it doesn't tell you much. It's more like history and what the patient actually has that can kind of tell you, oh, this patient might have isotonic hyponatremia or hypertonic hyponatremia. So if they, in the absence of that, and you're not really sure why this person has hyponatremia, you can get serum osm. But to Adrian's point, because of this reason, serum osm isn't the best test sometimes to figure out, do we actually care about hyponatremia? Whew, that was a lot of information. What questions do you have about this portion? Great. We'll move through. So let's go back to the algorithm. We'll keep coming back to the algorithm. We asked the question, do we care? And we got the serum osm with the caveat to determine if we care. If the serum is not low, meaning it's not hypotonic and it's not going to move water, then we don't really care. And the examples of this are isotonic and hypertonic hyponatremia, and these are the reasons. Okay, we got that part. So what if serum osm's low? Then the answer is yes, we do care. And this is hypotonic hyponatremia, which is when water is actually going to move in and out of the cells. So we care about this. So the reason why you're hypotonic is there's too much water. So that's the question that we need to be asking ourselves, like, why is the balance off now, as opposed to the other scenarios where the balance was pretty even? Why is there more water? And the answer is like pretty simple in my mind anyways. You have too much water in your body because there's too much water going in and there's not enough coming out. And the too much water in portion is the easiest, and the answer that third-year medical student will always give you, why is this person hyponatremic? Are they drinking too much water? It's not as common. You have to be drinking like 2 liters an hour for hours for this to happen, for kidneys to not be able to compensate. But the not enough water out portion, like the kidneys are just not getting rid of the water. Kidney failure, low solute intake, we'll go over this in a sec, but what's physiologically different from the other reasons is if the ADH is on. So we'll talk about this a little more in depth. And ADH stands for anti-diuretic hormone. So when ADH is on, just a simple reminder, your body's reabsorbing water. So in your urine, there is less water. It's more concentrated. So we can't talk about ADH without looking at the brain and the nephron. So here's the thalamus and pituitary, which to me always looks like scrotum. So hypothalamus makes ADH and it gets stored in the posterior pituitary. So what makes the hypothalamus release ADH is if the serum has high osm, if it's hyperosmolar, then it makes sense. So our body wants to retain water to keep the osmolality, right? Or another scenario is the baroreceptors, like in our aortic arch and carotids and things like that. If it's firing less, meaning the body sensing less volume or less pressure, I should say, then that stimulates ADH secretion. Angiotensin 2 can also stimulate secretion. So we can think about like what are the scenarios that stimulate angiotensin 2. And sympathetic tone can also, and I think this is why like post-op patients who have like a lot of pain can have SIADH and have ADH secretion. So then in these scenarios, ADH gets secreted and it acts on the collecting duct, and then it reabsorbs water back into the body. So the urine gets really concentrated, but the serum gets diluted, right? So if ADH is acting in the body, your urine osm, your urine concentration will be high, right? Let me say that one more time, because if you remember anything, you should remember this. If ADH is on, urine osm is high. Have I convinced everyone of that? Anyone doesn't buy it? Okay, cool. If ADH is on, urine osm is high. So back to the algorithm. So serum osm is low. Serum osm is low. We're like, okay, so what else is going on? We ask ourselves, is ADH on? Because like just pathophysiologically, it's going to be different, right? If ADH is on, the question you're asking is ADH on? The test that you're going to get to answer that question is urine osm. And if ADH is on, then urine osm is going to be high. If ADH is not on, then urine osm is going to be not high. It's not necessarily going to be low. It's just not going to be high. It's not going to be like above your serum osm, for example. And we call this ADH independent, meaning there's a reason the kidneys can pee the water out. It's not that the ADH is telling the kidneys to not pee the water out. They really want to pee the water out, but for some reason they can't. So let's talk about that real quick, because I think this is the coolest pathophysiology in my opinion. So I know there's like a lot of math out there to explain this. It tends to lose people. So I'm just going to put it this way. Your kidneys can't just like make your urine pure water. So like your specific gravity can never be just 1. It can be 1.000 whatever, but it can never be just 1. So the maximum dilution of urine that your body can get to is like 50 to 100 osm. So that's pretty dang low, but it's physiologically impossible to get lower than that. Your body needs osm or like solute to pee out the water. So what happens, and when I say osm, I mean, or solute, I mean like sodium, potassium, and also urea, which is like byproduct of protein breakdown, right? So if you don't have the solute to make urine, then, and if you keep drinking water, your body can't get rid of it, right? If you don't have the building blocks for the urine. So if you only eat toast and drink tea, which is mostly water, and if you only drink beer, which is honestly mostly like a little bit of carbs and like a lot of water, then carbs break down to just water and CO2, which we blow off, right? It's not creating urea, which mostly comes from protein breakdown. So then water builds up. You don't have osm to pee it off. So then you get hyponatremic. This is a scenario where you need to be careful with overcorrection, because I think like people tend to just get IV fluids, right? Because once the kidneys start seeing that osm, like normal saline or LR, once that osm gets delivered to the kidneys, they're like, oh, great, let's pee it out. And then just like start dumping out water. And then their urine output goes up. And then you should really be worried if their urine output starts going up like that after you give them osm, because their sodium is going to correct very fast. So if you think somebody has like tea and toast or a beer potomania, and if you think they've had it for a long time, you need to be careful. Okay. Renal failure. I don't think I really have to explain this to you. Like if here is a delicate mechanism of how water gets handled in the body. And if that's failing, then you can't pee out water, right? So ESRD patients, like before their dialysis days, will have hyponatremia, or like people who are getting like acute renal failure, they can also have hyponatremia. Let me stop there and see if I can clarify anything. Okay, great. So we're back to the algorithm. We asked ourselves, is ADH on? And we got urine osm to answer that question. If urine osm's not high, that means ADH is not on. So whatever's going on has nothing to do with ADH. It has more to do with like, am I taking in too much and the kidneys can't pee it out, right? But what about the scenario where urine osm is high and ADH is on? Then we have to think about, why is ADH on? Or another way to put it is ADH on for a good reason? And let's then go back to this diagram and think about the reasons why ADH might be on. Besides the osmolality, all the like decreased firing of the baroreceptor, increased sympathetic tone, angiotensin II, all of this can happen when there's not enough flow to the kidney. So like low effective arterial blood volume can cause all of this, right? So let's think about angiotensin II a bit. It's a part of RAS, right? Renin, angiotensin, aldosterone system. So angiotensin II goes to aldosterone. Michelle, so to confirm, does diuretic not affect urine osm? So that is a great question. I don't think it does. It'll affect urine sodium, and we can talk about it a little more. And I think a better question to ask yourself is, if you're thinking about if diuretic is causing the hyponatremia, does urine osm really matter? Like, is it going to tell you much? But we can get back to that point. So angiotensin II leads to aldosterone that acts to the proximal, distal tubule and collecting duct, and then it reabsorbs sodium. So ADH reabsorbs water, aldosterone reabsorbs sodium, meaning what's coming out of the nephron, which is urine, sodium concentration will be low. Then maybe this is why Meghna hates this, because like, when is it low, when is it high, right? Let me repeat this, because again, if you remember anything, the ADH thing and this thing you need to know. If RAS is on, if aldosterone's on, urine sodium is going to be low. If RAS is on, urine sodium is going to be low. So let's go back to the algorithm. ADH is on, AH is on. No, I will convince you, Magna, that this is actually like once you get these two things, if you remember just these two, nothing else really matters. So if AH is on, then you ask yourself, is there a low state to the kidneys, low flow state to the kidneys? Is that why AH is on? Because if that's the case, that's like a normal physiologic response, right? So if then the test that you get is urine sodium, then you have low state to the kidneys, which I think we have enough education to know about this. If true hypovolemia, true volume depletion from diarrhea, vomiting, poor PO intake, hemorrhage, whatever have you. There's venous congestion due to heart failure. There's backup, so the kidneys are not seeing like enough flow into the kidneys. Or if somebody has really bad cirrhosis, everything's leaking out, low intravascular volume. So there's low flow to the kidneys. So these are the reasons where RAS will be on and ADH will be on, because all those things are firing, and you can confirm that it's a low flow state with urine sodium by confirming RAS is on. To Michelle's point, urine sodium might be artificially high if somebody's on diuretic or if somebody already got IV fluids. So Michelle, to your point, I might ask, if you're getting to a point like you're getting urine osm, or like urine sodium, you already got the. Oh, I guess your question is, if you got urine sodium and if it was high, then we already said that ADH is on. So whether diuretic, but you're saying if they're on diuretic, how do you know that it was actually high? Like if it does elevate the urine sodium, does anyone know if diuretic increases urine sodium? Or sorry, urine osm. See, I told you this would happen. Can I look into that? Michelle, I'm gonna get back to you on that. If it could like artificially increase the urine osm. No, that's okay. So like, okay, so urine osm, only think about is the only thing it can tell you is ADH. Like, is ADH on or not? If urine osm's high, you say, okay, ADH is on. I'm pretty sure it doesn't elevate, like diuretics don't elevate urine osm. Like it's not gonna mess with that. It's gonna mess with urine sodium. So when you look at urine osm, the only thing you're gonna ask yourself is ADH on or not? And with urine sodium, the only thing you're confirming is RAS on. So is there low state to the kidneys? So like, is ADH on? Being on makes sense because when it doesn't, if ADH is on but there's not low, the flow to the kidneys are fine, then that's what we call ADH being on inappropriately. Okay. Rima, Center for a Cirrhosis patient and not know. So I might say if somebody has cirrhosis and has hyponatremia, I might also look for like, or if their like blood pressure is a little lower and their albumin is low, like if they're like reason, then their hyponatremia probably is from like low intravascular volume. And it can be tough because like cirrhosis patients are on diuretics, right? So like when you get urine sodium, it might be high, but if they're not, and you can get urine sodium to like confirm that there actually is low flow state to the kidneys. But I will say, like, if this is all kind of like, you get the labs, but you also have to look at the patient and you also have to look at the history and like ask yourself, like, does this make sense? Like, what's the most likely scenario? Yeah. And I think like the low sodium in cirrhosis, I think correcting it matters less unless they're nearing liver transplant, because they're going to be kind of like chronically low anyways, and the like 120s, like that's pretty common. But once you kind of reverse that portal hypertension, you turn off ADH like that, and then you like overcorrect like crazy, or like you correct like that. So then that can cause problem. Yeah. Yeah, Lauren, great question. I am intentionally not talking about numbers because we can all look that up. I think it all has to do with concepts here, but like low urine sodium to me is under 20. Like that's very, very low. Um, but below 40 is generally low also. Okay. SIADH, I'm gonna call it SIADH. A lot of things can cause it. Brain can cause it, drugs can cause it, infection can cause it, hypothyroidism, adrenal insufficiency, malignancy. What can cause SIADH, right? So just know if ADH is on, if there's no low flow to the state, if the flow to the kidneys are normal, then it's inappropriately on. It's literally called syndrome of inappropriate SID or syndrome of inappropriate ADH. So we've come to the end of the algorithm. We asked ourselves, do we care about this hyponatremia? And we get serum osm-ish to answer that question. It's when it's low that we say we care. Then we ask ourselves, is ADH on? Because the pathophysiology is going to be different. If ADH is on, urine osm is going to be, answer to yourselves, high, because urine is being concentrated. So if it's not high, then you have to look at, okay, then like you're either drinking too much or not peeing enough, right? If it's high, then you have to ask yourself, is ADH on appropriately, meaning is there low flow state to the kidneys? And you answer that question by getting urine sodium, because that's going to tell you if RAS is on. And if RAS is on, urine sodium is going to be, tell yourselves, low. Then you say, okay, like if urine sodium is low, if RAS is on and ADH is on, it's low flow state, and you can go from there. If it's not, then you say, okay, ADH is on for like no good reason. So that's SIDH. I'm gonna like I know we're almost out of time, so we're gonna very briefly talk about the osmotic demyelination syndrome. This is what we worry about the most. So briefly, just pathophysiology. When serum tonicity falls, our brain actually adapts. Without this, we would all get cerebral edema and die whenever our serum tonicity drops. So it increases ICP to like squeeze out the volume. It pushes solute out of the cell, so like potassium and other things like out of the cells to kind of like match the tonicity. And then this actually starts happening within like 2 to 3 minutes. So like if you were like really thirsty and like chugged like a bunch of water, this actually probably happened and like protected your brain while your kidneys are like trying to compensate for the extra water. So the risk factors, known risk factors for ODS we're taught is a very, very low serum sodium presentation, like lower than 120. And if you've been hyponatremic for a longer period of time, like more than 2 to 3 days, then the risk goes up. And if you correct it too rapidly, we're taught that it can be a risk factor. And also alcohol use disorder and hypokalemia are also risk factors for developing ODS. So this paper came out this year in March, and I thought was really interesting for a reason. It looked at like over 20,000 patients with hyponatremia in like 5 different hospitals in Toronto. Over the course of 10 years. So I think this is a pretty good data set. And they diagnosed ODS by imaging, so either CT or MRI. And then people who had DI or hyperglycemia were excluded from this. So the results showed rapid correction is really common. It's like almost 20%. Like almost 20% of the patients who had hyponatremia got rapid correction. But only 12 patients out of all these patients got ODS. That's less than 1%. And 7 of them, which is more than 50% of people who got ODS, did not have rapid correction. So out of like 23,000 patients, only 12 patients got ODS, and half of them didn't even get overcorrected. But the sample size of people who got ODS is small, so it's hard to know the risk factors. But the ones that they did note are initial sodium for people who got ODS were almost always lower than 110. And they always had positive alcohol level. A lot of them had positive alcohol level at presentation, kind of alluding to like the known risk factor of alcohol use disorder. And hypokalemia was also present. That is a known risk factor. And this I thought was interesting, that at presentation, their urine sodium level was lower than 30, meaning I alluded earlier that like hypovolemia, like true hypovolemia is also a risk factor for overcorrection. I wonder like if at like really low state, it's just like easier to correct too fast. Although I had just demonstrated, or like this study might have alluded that overcorrection has nothing to do with developing ODS. So maybe there are other risk factors that we need to be looking at where people tend to get ODS more. All right, we're at the end of this crazy journey. Remember, Josh, yes. Oh, in this paper, I don't think they called it out specifically to my knowledge, but it is a known risk factor. So like I said, the compensation that the brain does to match the hypotonicity, the process is complete in 2 to 3 days. It happens really fast and it's complete in 2 to 3 days, which is why we worry about anything that has been going on for more than 2 to 3 days, because we are worried that it's going to affect the brain cells. So early identification of why hyponatremia is happening is important to prevent complications from either mismanagement or getting worse. We only worry about hypotonic hyponatremia. Serum sodium is a surrogate for serum tonicity, which is why we get serum sodium. And ODS is extremely rare, but it's a real complication, and overcorrection might not be the only kind of risk factor that we look out for. But if you forget everything from this presentation, I like ask of you to just remember these two things. If ADH is on, urine osm's high. If RAS is on, urine sodium's low. You know, like you already know when ADH is on, like what turns ADH on, right? We're all internalized residents. You already know what turns RAS on. So if you forget everything and all the algorithm, tonicity, whatever, just ask yourself, like, is ADH on or off? Is RAS on or off? And what condition makes sense of this?
All right.
I seriously, yeah. Anyways, that's all. Here are my references. I know we're out of time.
Thanks so much, Lily. That was a great talk. Really appreciate that. I learned a lot myself on a topic that I have always felt confused about, despite having so much education on. And then I'm just going to one more time share this wellness questionnaire. I spoke to Yuri, and apparently you just have to fill out the first set of questions to get to the actual wellness questions. If you're just seeing like questions about rotation, you're on